The next presentation will be given by Johann Hammer. Well, there's a name similarity to my name that comes from the fact that Johann is my brother, and he is at the University of Vienna, and we have worked together in the field of carbohydrate malabsorption and intolerance for several years, with Johann taking the lead in all of the symptom aspects and the lead in the process of establishing and validating the carbohydrate perception questionnaires. Johann will tell us about malabsorption and intolerance testing, performance of tests, and interpretation of tests. Please go ahead, Johann.
Dear audience, thank you for attending. I'm presenting on behalf of the European Breath Test Group the European Guideline on Carbohydrate Malabsorption and Intolerance Testing, Performance and Interpretation. As you can see from the title of the presentation, the topic of my talk is not about one clinical examination, but two examinations. The one clinical examination is carbohydrate malabsorption testing with the breath test after a carbohydrate challenge. And the other clinical examination is a carbohydrate intolerance test. That is the test-specific evaluation of symptoms arising after carbohydrate ingestion. There was a broad consensus that in order to be able to compare breath tests performed in different laboratories, we need defined test protocols. Exempt are research projects in which test protocols can be varied depending on their aims and hypotheses. The panel members want to point out that some of the carbohydrates used in breath tests are not completely soluble in water, and a suspension of the sugar is appropriate. It is discouraged to dissolve the carbohydrates in hot beverages or foods that are rich in the test carbohydrate to be tested because of potential interference of different components of these test meals with GI function. How shall breath samples be collected? Accurate results from breath testing rely on proper preparation of patients and instruction on how to perform the breath test maneuver, and on reliable sampling of expiratory air. Different sampling and measurement devices are commercially available and can be used. Breath samples are stable for 6 hours at room temperature, and if measurements are delayed beyond this, storage at minus 20 degrees centigrade is needed. How shall patients be prepared for the test? It was general consensus that patients should wait 4 weeks after an antibiotic therapy and 2 weeks after colonic cleansing, as there is strong evidence that these procedures may alter bacterial composition and bacterial metabolism and thereby hydrogen production. High fasting levels of hydrogen in exhaled air may be the result of high fiber meals on the previous evening. Therefore, foods containing poorly absorbed fermentable carbohydrates and dietary fibers should be avoided at least on the day before breath testing. In constipated subjects, it may be preferable to avoid such foods for up to 48 hours, although there is no strong data supporting this. The majority of authors recommended performing the test in the morning following an overnight fasting condition and recommended mouth cleansing with an antiseptic solution. A fast rise in hydrogen concentration may be due to oral bacteria and can be prevented by mouthwash with 1% chlorhexidine solution. Smoking and physical exercise that may result in hyperventilation are not permitted before or during the test. The agreement levels to both recommendations were high, although there are no strong data in the literature on how long smoking shall be avoided. Hyperventilation, such as during a physical exercise, reduces breath hydrogen concentration and therefore should be avoided. Different drugs, including probiotics, may affect GI transit and bacterial metabolism of carbohydrates and therefore should be stopped at least 24 hours before the test, if possible. Whether drugs can be stopped remains at the discretion of the clinician. However, information on drugs taken by the patient at the time of breath test is needed for correct interpretation of the results of the breath test, and results should be interpreted with caution. Is there a need for the measurement of additional gases besides hydrogen to improve the diagnostic value? Measurement of additional gases in the exhaled air may increase test accuracy, and this must be weighed up against higher costs of equipment and potentially more complicated breath collection. The panel has agreed that the measurement of methane excretion in breath may be helpful if available. Methanogenic flora may contribute to low rates of colonic hydrogen accumulation, resulting in false negative tests in hydrogen breath tests in up to 20% of patients due to low hydrogen production or non-excretion. Some breath test analyzers use algorithms based on the measurement of carbon dioxide or oxygen to correct for incorrect breath sampling. In some cases, these additional measurements may be helpful. Why shall symptoms be recorded after a carbohydrate challenge, and how shall they be recorded? In symptomatic patients referred for the evaluation of the clinical suspicion of carbohydrate intolerance, an increase of breath hydrogen after ingestion of the suspected carbohydrate does not confirm that the patient's symptoms are caused by malabsorption of the tested carbohydrate. Documentation of the relation between carbohydrate ingestion and the occurrence of symptoms is of importance for correctly assigning symptoms to the ingestion of the test carbohydrate and should be the main indication for treatment aimed at improving abdominal symptoms. Therefore, the panel agreed that recording of symptoms manifesting after carbohydrate ingestion is an integral part of a carbohydrate challenge test. In order to reduce bias, symptom assessment should be performed with a validated test-specific assessment tool. The combination of carbohydrate breath tests with symptom assessment allows for the determination of 4 different entities after a carbohydrate load: maldigestion or malabsorption plus symptoms, maldigestion or malabsorption only, symptoms only, and none of the above. The statement that a positive and long-lasting response to dietary intervention may confirm the diagnosis of carbohydrate intolerance was agreed upon by 85%, while 5% of the panel disagreed. How shall the breath test and the intolerance test be performed? A watery solution of the carbohydrate to be tested is appropriate for hydrogen breath testing and symptom assessment. For lactose measurement, a dose of 25 to 50 gram lactose is recommended for breast testing. For symptom assessment, a dose of 25 gram lactose is considered adequate. In the case of fructose measurement, a dose of 20 to 25 gram fructose is recommended for both malabsorption and symptom assessment. The recommended test duration is 3 to 5 hours, but can be shorter if a positive diagnosis for both malabsorption and intolerance is confirmed during the test. The optimal interval between breast collections and symptom assessments is considered to be 30 minutes, while a 60-minute interval may be acceptable. Some experts recommend shorter intervals of symptom assessment in some clinical questions. A diagnostic cutoff of 20 parts per million above baseline has a reported specificity of 100% and a sensitivity of 60% for the diagnosis of malabsorption. Reducing the cutoff increases sensitivity at the cost of a reduced specificity. If concurrently with the breast test, a scintigraphic imaging of intestinal transit is performed, then a lower hydrogen cutoff may be appropriate. There was general agreement that blinded testing for intolerance is not required in routine clinical practice, and the minimal reporting criteria for the breast test should include a statement whether there is evidence of maldigestion or malabsorption and evidence of intolerance. And finally, what is a time course of symptoms of carbohydrate intolerance? Symptoms of lactose intolerance are diarrhea, abdominal pain, bloating, flatulence, and nausea. Various symptoms arise at different points in time after carbohydrate ingestion, and the duration of individual symptoms may differ as well. The majority of intestinal symptoms occur in the first 4 hours after a carbohydrate load, but symptoms such as pain, bloating, and flatulence may precede onset of diarrhea by several hours after carbohydrate ingestion. Therefore, it is recommended that symptom assessment may continue beyond the duration of the breast test, although food that may be ingested after breast testing has ended and the patient has left the outpatient clinic may considerably influence abdominal symptoms. This ends my presentation. I want to thank all members of the European Breast Test Group and want to thank for your attention.